scenarios we talked about before you got here that they'll throw at you to see what you have to say about it.
Okay.
All right, let's welcome Dr. Suttherland.
It's good to see you guys. How long has it been? A couple of years?
Yeah, at least.
I think my wife was asking me how frequently do I come out. And I said it feels like I go out there every year, but I looked at my calendar. I know that's not true.
Yeah, no.
Well, what I'll do, I think I've been here for 10 years, and I think a lot of you guys have made it through my clinic. At least a number of you are looking very familiar. So I guess we're doing a good job keeping you here. But for those of you who don't know me, I'm Doug Suttherland. I just celebrated my 10th year in Tacoma. So, yeah, I know. I can't believe it. The hair is going. Kids are getting older. But prior to that, I went to medical school at USC and then Georgetown for my urology residency, and then George Washington for my fellowship in oncology. And I haven't had a different job than Tacoma Multicare. So I guess I have some staying power there. I have some history, and like you heard, I've been here a couple of times. Now the last couple of times that I was here, usually I was given an assignment. I think the last time we were talking about prosthesis, like incontinence and penile implants and such. Another time I recall giving a lecture about MRI of prostate. I have no canned talk for you tonight. There's no fireplace next to me, but the plan was for this to be more useful and try to make it pertinent to all of you. So if there are specific topics or questions that I need to hit on tonight, oftentimes this group is a mix of patients who have had their treatment long ago and relatively new. So I'm happy to discuss the whole breadth of prostate cancer or get as laser focused as you want. The three topics that came across in our email a couple weeks ago was active surveillance. How is that being done now? How has that changed with our new genomic testing? How has that changed with MRI-guided biopsy? And then I think there was a second question specifically about MRI. Where are we at in 2018 with regard to MRI in general for prostate cancer? But those are two pretty specific topics. And so I can blow that up and get into greater detail or broaden it out and go in any which direction you'd like to go. But just as a show of hands, just so I have an idea of who I'm talking to, how many of you are recently diagnosed with prostate cancer, let's say within the last couple of years? And how many of you have been treated, but as far as you know, cured of prostate cancer? Prostate cancer is gone. And how many of you have prostate cancer, but it's metastatic and we are still battling that? Okay, perfect. And just another show of hands, how many of you came from active surveillance before going to treatment or on active surveillance now? Okay. And how many are surgical patients, prior prostatectomy, and prior radiation of any kind? Okay, all right. So not too much radiation here, seems. That's a little unusual. Okay.
Post-surgical radiation.
Okay. And how many of you had a prostate MRI? Just out of curiosity. Okay, so still a small number, still a relatively small number. Okay. Okay, well, how many of you have interest? Most of you have been treated, and most of you have not been on active surveillance. Is that a topic that you all want to hear about tonight, or is that not? How many of you would be interested in active surveillance talk, just out of curiosity? Okay. Well, why don't we start there?
Sure.
And then that'll dovetail into the MRI talk. I know that Porter was here recently and talked to you about robotics, so given that Jim is sort of a preeminent name in the world, I don't think you can have any more questions about robotics after Dr. Porter. If he didn't answer it, then I certainly cannot, I don't think. But Active surveillance. So I think it's probably important to say that by far and away, my recommendation is mostly active surveillance for most of the patients who I diagnose and treat now. And that is certainly not the case when I was first here in 2008. So within my career of only 10 years, really the management of the disease has completely and radically changed to, when I first came, I was doing 5 to 7 prostatectomies a week. Wow. To give you some idea. Pretty much if you were diagnosed, you were getting treatment, whether it was radiation or surgery. And now, I think this year I'm going to clear maybe 25 prostatectomies for the whole year, maybe 2 a month. So the numbers have just radically changed. That's true also of our radiation patients. So by far and away, the most common statement I make after making a diagnosis of prostate cancer is I recommend we do nothing. And that's a function of how common it is for men to be diagnosed with low-risk prostate cancer that we're not even sure is cancer, we're not even sure it's going to harm or even has the ability to harm. If it's going to do so, it might take 20 years for it to happen. So that has been just a massive change since I would say about 2012. So we're going on 6-7 years of this shift. And so how would I say the 2018 update looks like at this time? So if I or some other urologist tells you we think active surveillance is the way to go for whatever the reason, we're likely not going to be checking your PSA but once every 6 months. We're probably going to do another biopsy 9 to 12 months later, but then we might not do another biopsy for 2 to 5 years, meaning that it used to be that we were every year, come hell or high water, you're getting a biopsy, and after that first year, if we don't see change, we're now doing it between 2 and 5 years. And very often now, instead of doing a biopsy, we're doing an MRI every year, every 2. And we're only doing biopsies if we see a significant change on the MRI. So I have multiple men in my practice who've made that decision. They've said, listen, the biopsies are not pleasant, I don't look forward to them, they cause me as much anxiety as they cause me pain, I don't want that anymore, let's do an MRI, and we'll only biopsy if there's a change on the MRI. So if you think of it that way, it's entirely possible for a man who's had a single biopsy and diagnosed with prostate cancer to maybe only get 1 more biopsy in his whole life before he kind of hangs up the cleats. And we're not talking about men in their 70s and 80s. We're talking about 55-year-olds and 60-year-olds, men who have quite a bit of life expectancy in the tank, relatively speaking. And so I would say that we are becoming as least invasive as... If you told me that I was never going to do biopsies on guys who had diagnosed and maybe did MRIs 10 years ago, I'm not sure I could have predicted that future. Not without some kind of fancy genetic test, but that actually hasn't happened. So that was the second thing we were going to touch on is what about these fancy tests? What about the proteomics, the genomics? How has that changed the game? And it's important to say that I didn't give you any financial disclosure, so I'm not paid by anybody, but multi-care for my urology work. There's very rarely a time where these genetic tests are making a major impact or a change in a man's decision. So, there's basically the genetic tests that are available, and every year we get 2 new ones. I don't know why it's only 2 or why we don't get 1 or 3, but it seems like every year we get 2 new genetic tests. And you can basically consider them in one of 2 categories, the pre-biopsy and post-biopsy type of test, right? So a 4K test, for example, is a recent example of a test that comes out that's supposed to be better than PSA. There's also a CX test coming out shortly, which is going to be apparently looking at actual DNA, RNA snippets. So this is the first time that we've had a true urine test that is apparently able to tell that there's cancer DNA in your urine without me even doing a biopsy. That's going to create quite an interesting uproar if that's actually true. But we can order tests to help us decide if it's likely that you have cancer, right? And now there's a host of genetic tests that we can order. But none of them actually make the diagnosis. None of them actually tell you, you are that guy with the short stick who has the really bad disease that's going to take you out if we don't treat you. That kind of information, that granular of detail does not exist yet. So it hasn't changed how we do things so much because the man is still in the hot seat trying to decide, kind of in a theoretical world, what would I do with this information? If I had cancer, like pretend I have cancer right now, would I actually treat it or not? Would I give up my quality of life to live longer or not? I mean, that is still the crux of the question, and it's still, unfortunately, purely theoretical. None of the tests that we have that have come out really push the needle far enough that men are like, okay, that's great. The test says I'm fine, so I'm just going to forget about this and go play golf. But they're close, they're getting closer, and every year this is getting better. So for those of you with sons who are starting to hit the age where this matters, 40 to 50 years old, it's very possible that one day he'll come in, instead of having a PSA test and a long drawn out painful question, and a biopsy, he'll pee in a cup, and then we'll tell him that's the situation. Okay? And then the second family of genetic tests are those that we can apply to the biopsy tissue or the radical prostatectomy tissue. So if somebody has a biopsy or they have the prostate removed, then there's a whole host of tests I can do to send that tissue off to a lab, and then they're supposed to be able to tell me specific stuff about the genetic test, like the genes of that cancer. So you all are familiar with what sampling error is, or sampling bias? Is that a term that anybody has no idea what I'm talking about? Meaning that I'm sticking a needle into a prostate that's some of you guys, it's as big as my fist. Right?
Yeah, we were.
But we have an organ that's about the size of my fist here, and I'm sticking a needle into it 6 to 12 times. Right? So I'm taking out a micro fraction, like not even a decimal point. My daughter, who's struggling with fractions right now, would not be able to quantitate the weight of tissue I take out with my needles. Right? So we know that with our current biopsy strategy, even with an MRI in my hand, it's a luck of the draw thing when I'm sticking my needle in there. So let's say I hit tumor, and let's say it's the Gleason 3+3 that I heard somebody say, right? So that's medical speak for, we're not sure this is really the type of cancer that's going to kill you. This is not aggressive stuff. So in theory, we can send that to the lab, and they'll tell us the actual DNA, the genetic makeup of that tumor. And is there something more to it than the Gleason score? Something more than what the pathologist can see with his or her eye under the microscope? Is there DNA in that tumor that will tell us that this is the bad stuff, even though it doesn't look that bad? So that's useful. That's really quite useful information, actually. And so that has penetrated our practices. But the problem with that test is that the guys who need that information the most, which is the guys who have low volume, like only a little bit of cancer on the biopsy, those are the men who the test results are least accurate for. In fact, many times, I've had a 50-something-year-old man in my office who comes in with a very small amount of cancer on his biopsy, and he wants to watch it, but he's nervous about it because he's young. He's still got 30 years, and he's got a couple kids at home still who are dependent on him. And he's not comfortable letting it ride. So we'll send that information off to a lab, and they'll call me back and they'll say, sorry, there's just not enough information, enough tissue here for us to give you what you want, right, what you need. So unfortunately, for a substantial percentage of men who are candidates for active surveillance who want to watch it, that test is not going to work. It's just not going to, they're not going to be able to run the actual test. And that's super frustrating. That means I'm going back and I'm going to do a saturation biopsy. Does anybody know what that means? That's just pure medieval torture, where I'm doing 20 to 50 biopsies on a guy, if you can imagine that, trying to get more tissue just so I can run this test. And not often, not unusual for a man to hear that story and say, well, screw it. If you're going to take out 50 pieces of by needle, might as well just take the whole thing out. Like, I don't want to go through that. That's not an uncommon reaction to the strategy. So unfortunately, the genetic testing that is in my office and I can order hasn't really changed the nitty-gritty decision-making, which is, do I want to trade in my sex life or my urinary function or my ability to hold more than 100 cc's of urine for the possibility of eradicating a disease that might not hurt us, unfortunately. So that's frustrating. But there has been so much cool stuff reported on recently that I do think that's probably going to change. Probably in my next 10 years, I'm guessing that that's probably going to be the next biggest shift, is that we'll get away from the Gleason score altogether. We'll just stop using that as a significant metric, and we'll just start sequencing genes on these tumors and telling people precisely what it is that they want to know, which is, what are the odds that this thing's going to get out? What are the odds that this thing's going to hurt me or kill me? And what's the timeline look like? I think all that information is very much coming. Just can't come soon enough, obviously. So that is, in a nutshell, active surveillance as it exists in 2018. It's our most popular treatment. I shouldn't call it treatment, management strategy. We are decreasing the frequency of biopsies. We are increasing the use of following tumors just with pictures on an MRI. We're waiting for the genetic testing to come to get us out of this whole biopsy thing altogether. But we're not quite there yet with that. MRI. First of all, does anybody have any questions about active surveillance that I just said? I spoke fast and said a lot of things. Is there anything that I left out? Or
is it too late to start it now?
Is it too late to start it now? No problem. We got a time machine right out the side door. Let's jump in there. Real back.
How about a prosthetic? Whatever it is we're talking about here now.
Prostate?
Prostate.
Well, see, the thing is, I don't think anybody would actually want their prostate back. They would just want the damage done by me removing the prostate to be taken back. And I don't have that one. Really, the truth is for a lot of the men who we treat, the prostate was causing them as many problems as it was helping. Right? By the time we get to our 50s and 70s, I mean, the number one complaint I get now, when I think about it, what I do on a day-to-day basis is I can't get to the toilet in time, I drink too much, I'm up 4 or 5 times a night to pee. You know, these urinary complaints are directly linked back to the size of a man's prostate and the fact that it's gotten bigger over time. So the prostate itself is not doing us a whole lot of favors at that age, but the act of destroying it, either surgically or with radiation or hormones, is obviously the problem, and we haven't figured out, there's no prosthesis for that. Yes, sir?
Can I go back a little bit?
Sure.
To the MRI part of this.
Sure.
When did you decide that the MRI was going to do the same thing as the needles?
Well, it doesn't do the same thing. Okay, so that I have to be
It doesn't
careful.
diagnose the same way?
It does not, right? So when we talk about the use of MRI, have you had Dan Lynn down here recently?
No, not recently.
Okay, so he would be a good guy to have if you come down, because he is, Dan is a really smart researcher, and he has a real negative bent on the MRI. He is not a huge fan of it. And the reason why he's not a fan of it, and at every single meeting he stands up and asks the question, are you ready to give up on biopsy altogether and just follow MRIs? He's just waiting for you to take the bait and say yes. He just wants you to, because he is just loaded with data that shows that if you do that, you're going to miss clinically important cancers. So, and he's right. It's not that it's a sham procedure, but there are some really bad guys, bad cancers, that are somewhat invisible on MRI. That happens. That's a real thing. Dan's biggest beef is not that group, because that group is relatively rare. For the most part, MRI is pretty darn good, actually. But Dan's biggest beef is that the people who are reading the MRI are not yet competent at doing so. It is not the same as getting an MRI of your knee because you got some knee pain. It's a whole different ballgame. Okay, so it's not even really fair that we call it MRI. Like, how many of you have had MRIs of your hips, knees, or backs, or heads, right? So it's super common. It's like getting a chest X-ray. Okay? And when you do an MRI for one of those problems, yes, there's some specialization there. I'm not trying to take anything away from the radiologist at all. Okay, when I look at an MRI of a knee, I don't really know what I'm looking at, right? But MRI of the prostate is as much of an interpretation of data as it is looking at images. So when you go get your MRI of your knee, what are they looking for? They're looking to see if your ACL is torn, or if your cartilage is gone, or if your meniscus is ripped, or if you got too much fluid. I mean, these are things that they teach you on the first day of radiology school. Interpreting an MRI of your prostate is more about looking at numbers. It's more about interpreting the data that the MRI is giving you. Yes, there's pictures involved, but there's something like 1,000 pictures for every single person who gets one MRI. And so what they're having to do is they're having to sift through all of that data. And that is not something they teach you on the first day of radiology school. In fact, you can go all the way through your training as a radiologist and never really get taught this because it turns out to be fairly complicated. So when Dan Lin puts his bait out there, what he wants to tell you is, well, you're not at UCSF where they invented this. You aren't coming from the National Institutes of Health where they did it for 10 years and they've got literally thousands of case studies and it's the same 3 guys who've been reading these pictures and they know what they're doing. And if they read your MRI, then you can rest assured that you don't have cancer. But your guy in Tacoma, well, he just finished his training program. He is not the same, right? And Dan has quite a lot of data to prove that point. So that's a long-winded way of saying that it's not fair to say that MRI does the same thing that biopsy does. That is not true. But it's as close as we've ever gotten. It's really important to understand that when I first started in practice 10 years ago, prostate cancer was entirely invisible to us. Unless you had metastatic disease where it had spread to some other part of your body so you could see the bone being eaten away, you can't see it with an ultrasound, CAT scan, MRI, bone scan, PET scan, you name it. We studied them all. And it was really impossible. It was like trying to catch an octopus. So it was just crazy. And so if you think about, if you consider for a moment where we came from, the MRI that we have now, even if I have somebody who is not a quote-unquote expert radiologist, it's still light years ahead of where we were before, light years. So now I can do a targeted biopsy. So the way that it is used, at least in my practice, the way I try to stay out of Dan Lin's doghouse, is I always recommend biopsying every MRI, the first MRI I do. Okay, so if I diagnose you with prostate cancer Tuesday, and we've decided that we're going to do active surveillance, then about 9 months from now, we'll do an MRI, but it's with the understanding that we're doing a biopsy immediately after it. So if the MRI shows something, like a bogey at 6 o'clock, my needle is going there. And if my biopsy confirms that what they're seeing on the MRI is not the bad, scary prostate cancer, then yes, I will flip a person to MRI follow-up only, because I've proven in this particular case that the radiologists are not botching it. A lot of men don't want to do the biopsy part. They just want to say, well, wait a minute, the radiologist didn't see anything, right? So you have to have a real careful conversation with that person, that just because it wasn't seen on that picture doesn't mean it's not there. Really need a biopsy to confirm it. But that's how it's being used. And as we get better and as the accuracy of our reads and experience of our radiologists gets better, it probably will shift more and more in that direction. For example, at one of the epicenters in the world, I'm blanking on the name, it's in London, England. They don't do biopsies unless you've had an MRI, and they only biopsy you if you have some of the worst types of interpretations on the MRI. So they feel so confident in their system and their radiologists and the way they're doing it, that it's a mandatory thing to have the MRI before you do a biopsy.
No more click, 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 click.
So we still have the clicky gun. I have a brother-in-law who is a mechanical engineer in academics, and every year we get together, and he's always asking me, what's your $1 million idea? Because he wants to invent stuff and get patents and whatever.
Tell him to get rid of the click.
Yeah, totally get rid of the click. If you could get rid of the click, okay, and just let the needle go in without a click, I think you'd have a lot of happy patients, but he's 33 years old and he doesn't.
I don't know if you want to surprise us or not.
Turn off the hearing aids.
Are they still doing with the
Doesn't work.
endorectal coil?
Still feels the click.
I honest to God have never ordered an endorectal coil. Really? So I refuse to order something that I wouldn't do. And having a coil in the rectum for 45 minutes, it seems wrong. I hesitate to do a 5-minute prostate biopsy on people. The 3T coil is the answer to that.
Okay.
Okay, so the 3 Tesla coil. So the only hospital in the area that I know of that does endorectal is St. Clair.
Okay.
And then St. Joseph's Hospital installed a 3T coil, which gives you the types of images that you get otherwise with an endorectal coil.
Now, do you impose the picture on your ultrasound? Is that?
Yes. Well,
So you see the MRI picture right on the ultrasound?
that's correct. Right. Fusion. Right. So, and then Multicare is installing their 3T
Okay.
apparently in Q1.
So you don't need the endorectal coil anymore because it's 3T?
You do not. There are some unique cases where the radiologist wants that. If a person has had rectal cancer, for example, and they've had radiation down there, or there's something else about the patient's prostate that makes it not very amenable to imaging. And the rectal coil will always be the best, like assuming it's done properly, because the coil is literally a few millimeters away from the prostate. So you're going to get crazy, beautiful images with that. But the difference between that and a 3T is not high enough to justify the pain and suffering of the endorectal coil.
I've had one.
That's
Yeah,
right.
notwithstanding the clicks, what type of contrast is entertained in this so-called MRI of the prostate zone?
They inject in your.
Yeah, what kind of contrast? Gadolinium is the biggest one they use.
It's the only one I know that they use at St. Joe's.
Yeah, well, can you get it two different ways, whether it's injected into your arm on the major vein or a topical on the skin, just where it could soak in, be less side effects for the...
No, it has to be injected.
You do know that gadolinium has got a black eye so far in the past 6 months.
Well,
No
so
matter where it's...
the reason why the injectable is going to be the standard of care for now is because one of the critical images, or I should say, one of the critical types of images that are done, it measures the density of the tissue as the contrast flows into it.
Oh, I see. So you have to have that.
You have to have perfusion of the contrast.
Okay.
So it's one of the sets of images that helps them to tell